and it's my absolute honor and pleasure to be here at the RSSDI 2021 conference, sharing the stage with an absolute galaxy of women with amazing achievements. And I know I'm speaking for many, many women who are passionate about improving health access to women with diabetes. So the topic that I've been assigned is to talk about whether we need gender-specific approach in the management of diabetes. And I'll go right into the heart of it as to why it's important to spend an entire 3 hours discussing management of diabetes in women. How different could it actually be from men? Although the prevalence of diabetes is greater in men, over the years in Southeast Asia and globally, the mortality rates are higher in women with diabetes. This is a slide from the 2015 IDF Atlas, and you can see how we are losing more women to diabetes than men with diabetes. And if you're wondering if it's any different in the 2019 IDF Atlas, you do see that while the mortality rates might be equal up to 60 years of age, beyond 60 years, it exponentially rises amongst women with diabetes as compared to men with diabetes. So if there is one reason why we should be speaking about this, it is absolutely this. So what is gender and what is sex? Why can't we just talk about biological differences, and why should we talk about gender sensitive approach? Sex or biological sex is a physiological or biological difference between the two sexes, attributable to chromosomes, to genes, to hormones, and their expressions and their effects on disorders. Whereas gender is a construct which goes beyond biological differences to include the societal norms which have been imposed on one sex of the species, which has repercussions on the economic access, the behavioral changes, or also the environmental factors which might be unique to the gender normative behavior attributable to that gender. And we will talk about how this could alter disease. And why should we talk about gender and not just biological differences? Because this alters both the behavior of the patients and doctors. It alters the disease perception by the person who's affected by the disorder. It also can affect help-seeking behavior, use of healthcare or access to healthcare, which is the theme for this year by the IDF. Also, could it potentially interfere with the decision-making of healthcare workers and also therapeutic response? So this is exactly why we should be paying more attention to a gender norm in the context of the illness of diabetes, which is all pervasive. This is the outline of the talk that I'm going to go about today. So this is a very comprehensive review which was published a few years ago to talk about the gender differences in metabolic disorders. While at younger age group, there are more men who are obese. As we age closer to 40 years of age, the proportion of women who have BMIs greater than 25 or 30 again rise exponentially. Why are we talking about obesity when this talk is about diabetes? Because the relationship between BMI and type 2 diabetes is completely different between men and women. If you take a look at the green dots on the bar, the rise in the incidence of type 2 diabetes occurs at a much lower BMI and also climbs up exponentially in women as compared to men. Of course, this is data which is out of India. How is this relevant to our lives in India? Very recently, the National Family Health Survey 5 was done, and the results of this was released recently. There hasn't been a national-wide assimilation of all the findings, but this is data from Karnataka, the state that I'm from. And if you take a look at the proportion of women and men who have BMI greater than 25 kg per meter square, it's at a whopping 30%, but it seems to be equal between men and women. But this survey is unique and different from the previous surveys because we also managed to measure waist to hip ratio in this survey. And what we found here was that up to 45% of women had a BMI which was greater than 0.85, which essentially means that every 1 in 2 women in Karnataka has visceral obesity. So if you're going to try and flatten the curve of projection of increasing prevalence of diabetes worldwide, and if there is one vulnerable population that you should be looking at, it should be women who present with obesity. Do they present with obesity and insulin resistance to us? Yes, they do in many, many forms. Anybody who's having a clinic do know that there are many women who walk in with this very common condition called polycystic ovary syndrome, which we tend to deem it as a reproductive disorder, but the seeds of insulin resistance are already at play over here. And if anybody is taking a gender sensitive approach to prevention of diabetes, this is probably the cohort that we should be targeting right from the start. Because not only is it a reproductive disorder, it is actually a metabolic disorder with reproductive manifestations in this stage, which could potentially translate into greater metabolic risk, which we can all alter by implementing changes. Of course, this we seem to completely miss through our fingers. And here is a slide to show you that as the amount of androgen level rises in women who present with PCOS, the number of components of metabolic syndrome keep progressively increasing, highlighting the fact that this is there are already features of metabolic syndrome here. But let me move on to, whenever we talk about women, we only want to think about pregnancy. What proportion of pregnant women do you think have hyperglycemia? Let us say in Southeast Asia. Up to 27% of women in pregnancy have hyperglycemia. That's every 1 in 4 pregnancies in our area is complicated with hyperglycemia. And we have amazing speakers coming in to talk to us about how hyperglycemia in pregnancy has long-lasting effects, altering the metabolic milieu in which the fetus grows, thereby increasing their risk of adult metabolic disorders. And if this is not motivation for us to take care of our women with diabetes, I provide more reasons for you as we move about. Is it only pregnancy, or is there anything else in the life cycle of a woman which could alter the risk of metabolic disorders? This is a paper which was done amongst Chinese women to document that greater the number of pregnancy that a woman went through, greater the chances of type 2 diabetes. Pregnancy is a stressor on your beta cells. So with every increasing pregnancy, your chances of type 2 diabetes increase. So do we ask for the number of children when we check at follow-up of women who present with GDM to quantify their risk for type 2 diabetes? Not really. This is another study which tried to look at the age at which the menopause was attained and the risk for type 2 diabetes. So for every drop in standard deviation of the age of menopause, the risk of type 2 diabetes increased. So there seems to be a tight interplay between reproductive transitions and metabolic disorders. This is again another slide to show you that the progression of NAFLD or fatty liver disease, which is now deemed to be the 6th component of metabolic syndrome, progresses faster around the time of menopause by itself. So, and it is now a very well-established risk factor for NAFLD. So around menopause, are we looking out for progression of fatty liver disease? When we have a blanket screening protocol for everybody, we are likely to miss out these nuances of treatment. And why is it important to do this? Because even at the same BMI, women tend to have a greater waist-hip ratio as seen physically by the National Family Health Survey. But here we have documentation to suggest that they have greater visceral adiposity as compared to men at the same BMI. So what about differences in consequences of diabetes in women? We have 2 fantastic professors talking to us, going into the nuances of the microvascular and macrovascular differences between complications. Women do have a greater prevalence of diabetic neuropathy and nephropathy, but probably I want to pause here in the difference in macrovascular complication, because this is the major cause of mortality amongst women with diabetes. While diabetes increases the risk of cardiovascular disease in men by 2-folds, in women with diabetes, the risk of cardiovascular disease is increased 4 to 5-folds. Of course, one might want to say that this was a study which was done in the 90s, where comprehensive diabetes care was not the regular routine care. Now it might not be so. So let me show you recent evidence. This is a large meta-analysis conducted by Peter San and group. They did 2 separate meta-analyses, one to look at diabetes as a risk factor for coronary artery disease and one for stroke. And what they found was this, that the relative risk of incident CHD was 44% greater in women with diabetes as compared to men with diabetes. And a similar study done to evaluate the risk for stroke also showed that women who have diabetes have a greater risk for stroke as compared to men. While traditionally, whether we like it or not, we're likely to hold on to a bias which says that stroke and coronary artery disease are less likely in women, but diabetes seems to still be a risk factor, which demolishes all the protection offered by the estrogen status. So when you're trying to look at where is this gap happening, when did this change, the presence of diabetes seems to increase a clustering of various parameters which could overall increase your risk for cardiovascular disease. So this was a study done amongst Japanese women. They looked at both women and men with diabetes and without diabetes, and they looked at the common cardiovascular risk profiles. And they found that amongst women with diabetes, there was a greater visceral obesity, greater blood pressure levels, greater LDL cholesterol levels. And what this is called as risk factor clustering. So if you want to select one vulnerable cohort of people with whom you want to do minimal intervention and get maximum results, that would be a woman with diabetes. So are there any other risk factors for coronary artery disease or cardiovascular disease which we are missing, which are specific to women? This is a study which showed that presence of PCOD increases the risk of cardiovascular disease. We have Professor Sarita Bajaj and Professor Mala Dharmalingam talking about this, about the effect of GDM and non-communicable disease, but also pay attention to the fact that if you have preeclampsia or pregnancy-induced hypertension, it could increase your risk of cardiovascular disease in your perimenopausal or postmenopausal windows. Do we ask these questions to the women whom we treat with diabetes? I don't think so. This is again another study published very recently, 2020 May, which looked at parameters which: did you have a preterm birth? Did you deliver a baby who was small for gestational age? Do you have vasomotor symptoms now that you're perimenopausal or postmenopausal? And then they correlated these 4 factors with your ASCVD risk score. And guess what they found? People who are likely to have vasomotor symptoms now, perimenopausally, or who have a past history of delivering a preterm child or a small for gestational child, had a much higher score for risk for CVD than the others who didn't. So there's very little that we've understood about the reproductive transitions, especially menopause and its effects on cardiovascular disease. But key factors which are specific to women, which we probably need to pay attention to more, is presence of PCOS, the transition of menopause, presence of GDM, PIH, and preeclampsia during pregnancy. Maybe we could add to that having preterm delivery or small for gestational age, which probably could serve as surrogates of vascular insufficiency or maybe preeclampsia, which wasn't picked up or treated well. Psychosocial well-being and diabetes is something that we always associate with women. But before we go on to a pause, it's very important to acknowledge that there is no such thing as a downtime for a woman's mind. There is 3 to 4 additional hours of household and childcare chores per day. If you do 3 to 4 extra hours of work, I don't think you can have any downtime. And so I'm not surprised that the prevalence of depression or anxiety is higher in women. But the point as to why, as doctors who are taking care of diabetes, need to acknowledge this is this. This is data from the Nurses' Health Study, which looked at a large group, 80,000 and odd women, and looked at self-reported depression and looked at their mortality rates and all-cause mortality over 6 years of follow-up. And this is what they found. When they broke them down into 4 groups, the groups which had both depression and diabetes had the highest all-cause mortality as compared to groups who had diabetes with no depression or depression with no diabetes, right? So that's exactly why it becomes absolutely our business to ask, how are you doing? How is your mood? How are you feeling? Those are questions that we definitely need to roll into the consult. Of course, the connection between depression and diabetes, many involving both hormonal and sympathetic system involvement, but it's the thing that is there. I do not even have the time to talk about the prevalence of sexual dysfunction, but there is strong correlation now between sexual dysfunction and emotional well-being and depression. And take a look at the column. The prevalence is anywhere ranging between 20% to 77% amongst women with type 2 diabetes. Do we have a screening program? It is recommended, but do we screen? Not really. This is a paper to show that just the diagnosis of diabetes in individuals with breast cancer just worsens prognosis and outcomes. So do we regularly push our women to screen for breast cancer? Do we have a protocol? Not really. Is there a treatment bias? I'm turning the mirror towards us doctors. By healthcare professionals towards women. This was the study which was called rightly the inertia study, which looked at whether a woman or a man was receiving statin or escalating therapy after an ischemic heart disease. And it was found that there was some inertia while starting statins or escalating therapy in women as compared to men by doctors. And these are people who already have ischemic heart disease, right? So this is something that we need to think about. So much so that now something called as the Yentl syndrome has become part of folklore in cardiology. Yentl is a movie in which Barbara Streisand pretended to be a Jewish boy so that she could learn the scriptures from her father, right? So she acted or cross-dressed like a boy throughout the movie. And now it is clearly understood that when women present with angina, you're less likely to receive a complete evaluation, you're less likely to receive a recommendation for an angiogram, and you're also less likely to receive complete and intense treatment for the cardiovascular disease as compared to men, which in turn translates into worse outcomes for women. And now this is a recognized entity now, and this is there's no escaping now, right? So we definitely need to go back and reflect on our own practices. So moving forward, Lancet 2020 had an entire issue on gender norms and its repercussions on health, and it called out for standardizing recruitment of people for clinical trials, because there's always been underrepresentation of women, and nobody's quite really looked at women-related factors or women-related adverse events or women-related responses to medications. And of course, changes in practice guidelines, and probably holding more seminars and summits like the one we're doing to bring focus to the differences between the two gender. So quickly to summarize, we will always need to talk about a gender-sensitive approach as long as there is inequality in gender roles in the society. Obesity seems to be rising disproportionately in women than men, even in India, especially visceral obesity. And we need to address this because BMI seems to correlate strongly with women for the risk of diabetes as compared to men. Up to 1 in 4 pregnancies in Southeast Asia is complicated from hyperglycemia. Multiparity, menopause are all risk factors for future risk of diabetes. Menopause is a window of transition which could increase the risk of cardiovascular disease and FLD. We are losing more women with diabetes than men with diabetes. And one of the important causes is the fact that they are at greater risk for stroke and coronary artery disease. Screening for depression is something which needs to be added. We need to acknowledge that there seems to be some therapeutic inertia coming from our ends, and design future clinical trials which will represent women. This is a photograph from Sunita Williams on a spacecraft. Notice that her legs are flying in the air, but there's a blue bar for you to fix your foot. If she fixes her foot there for stability, she loses sight of the window through which you watch out for any debris which is flying in space. The man, on the other hand, has his foot fixed on the blue bar and is still able to look out of the window. As long as we are making spacecrafts designed only for men's health, we will need to continue to fight for a gender-specific approach for the management of women with diabetes. Thank you so much for the honor, and I hand over to the chairpersons.